Hi everybody, Erica Henry here to talk a little bit more about pacemakers and give you some more in-depth information regarding pacemakers, their basic function, and what types of patients would require the implantation of a pacemaker. So again, we have the beautiful heart picture. Here in the corner you can see the pacemaker device. Typically this would be implanted in the chest or in the abdomen, and it's connected to the heart by wires called leads. Patients that typically require the implantation of a pacemaker usually have some sort of arrhythmia that needs to be properly controlled. So patients with bradycardia, where their heart is beating too slow, patients with tachycardia, where their heart is beating too fast, patients with abnormal arrhythmias such as atrial fibrillation or atrial flutter, or patients that have different types of heart blocks. First degree heart block, Mobitz type 1, Mobitz type 2, or third degree heart block. So the way that a pacemaker works is it sends small electrical impulses from the device itself into the heart, and this prompts the heart to beat at a normal rate. So it uses those low energy impulses to help overcome the faulty electrical system of the heart. Then you also have the AICD, which is the automatic implanted cardioverter defibrillator. And the way that this works is it uses electrical shocks to overcome typically more dangerous arrhythmias. So your ventricular tachycardia, your ventricular fibrillation, those more lethal types of heart rates. A lot of the new AICDs, though, also function as pacemakers. So first I want to start out by just giving a quick example of a patient that I cared for in the ER a couple of weeks ago. So this was a 74-year-old female. She came into the ER by ambulance from home, and she had the implantation of an AICD pacemaker. She had a history of AFib, which she was on anticoagulation for. She also had a history of ventricular arrhythmias. She had had runs of VTAC and VFib in the past. So she, although 74 years old, was outside gardening, and she suddenly became very lightheaded and dizzy, and she felt her AICD fire multiple times. I think it was about 3 or 4 times that she felt this AICD fire. She then called her daughter, who called an ambulance in to bring her into the ER. So a couple of things that you want to find out about this patient. What types of things do you want to find out that are important? You want to know the type of pacemaker. The 3 different types of interrogation devices we have in the ER is Boston Scientific, Medtronic, and St. Jude's. There are other types of pacemakers as well, so it's very important that you find out the type of device that this patient has implanted. You also want to find out the indication. Why do they have this pacemaker placed to begin with? Do they have AFib? Do they have a history of ventricular tachycardia? Do they have a history of heart blocks? What is the reason for why this pacemaker was placed initially? You also want to find out the date of implantation. Symptoms: was the patient short of breath? Were they dizzy? Were they having chest pain? Did they feel a shock the way that this patient did? What kind of symptoms did they have that prompted them to come into the ER to be evaluated? And you want to find out the types of medications that they're taking. Are they taking blood pressure medications? Are they on anticoagulation? Are they on anti-arrhythmic medications like cardizem or amiodarone, etc.? So the next thing you want to do is obtain some information through your physical assessment. You want to do a 12-lead EKG to find out what rhythm they're in currently. You want to get a chest x-ray, and then of course you want to interrogate the pacemaker. You want to find out what was the pacemaker doing at the time of the event. So I brought here an interrogation device with me so I could show you a little bit about how they're used in the ER. I'm going to take this off so I can kind of give you a better idea of what they look like. So here we have an interrogation device that we often use in the emergency department. This particular one is a Boston Scientific. So let me show you how to do it. So here's the device. So all you have to do is plug it into the wall. It has the small device here, and then it has a wand. So all you're going to do is you're going to take this wand and you're going to place it over the patient's chest or wherever it is that the pacemaker is implanted. So here's my friend. We'll call him, let's pretend like it's my 74-year-old patient that came into the ER. So we'll call her Mary. So here's Mary. She came into the ER. We're going to tell her exactly what we're doing. We want to interrogate your pacemaker, find out what it was doing at the time of the event. So you take your wand, which you have here, you place it over the chest, And it'll say here, press here to read data. So you're going to press on the screen, it is going to identify the device, and then it is going to read exactly what the heart was doing at the time of the event. Usually the pacemaker will take, or the device rather, will take a couple of minutes to read the pacemaker itself, and then the information will be transmitted to whatever company it is that the pacemaker is. So this one, for example, is Boston Scientific. So the information will be sent over to Boston Scientific. We, the nurses, typically get a call from the company saying, this is what the pacemaker shows, this is what the pacemaker was doing at this time, whether or not it delivered shocks, and then they'll send a full report via fax to the ER so that it can be seen by the ER physician and the cardiologist, and we can find out exactly what was happening with the pacemaker at the time of the event. Regarding pacemaker checks. So even if a patient does not come into the ER for chest pain, shortness of breath, something related to, an acute issue with the pacemaker, they should have a follow-up appointment with their primary care physician or their cardiologist every 3 to 6 months to have the pacemaker checked. It's very important to go and just make sure that the device is functioning properly and that the battery life is still good on the pacemaker. My particular patient came in because she felt the shocks in her chest, but there's other indications as to why a patient may need to have their pacemaker interrogated in the ER. So if you have a patient that comes in after having a syncopal episode or a near syncopal episode, they're feeling lightheaded, they're feeling dizzy. Patients that are having chest pain or feeling palpitations in their chest, patients who are feeling short of breath and have a history of cardiac issues such as cardiac surgery, congestive heart failure, or patients who were in a sudden cardiac arrest and achieved ROSC, return of spontaneous circulation. These types of patients, you also want to interrogate the pacemaker because then you can find out what exactly it was that caused the cardiac arrest. Did they go into a VFib, a VTAC? Was it asystole? And what was the pacemaker doing at the time of the event? Was the pacemaker not sensing properly and it wasn't doing its job? So it's very important for these types of patients that you interrogate the pacemaker and find out as soon as possible what was happening at the time of the event. So the next topic we're going to talk about is the placement of pacemakers in the emergency department. So patients can be paced in a number of different ways in the ER. They can have external pacing, they can have emergency placement of a pacemaker in the ER, or if the patient comes in and they're symptomatic, we can rush them down to the OR for emergency placement of a pacemaker in the operating room. So I just want to first discuss some indications as to why a patient would require to be paced when they arrive in the ER. So first would be symptomatic bradycardia. So a patient comes in, they have a heart rate in the 20s and they're symptomatic. They're having chest pain, they're diaphoretic, they're short of breath, they are pale, they're lightheaded, they're dizzy. Oftentimes we'll start with a medication called atropine. If this medication is not effective, then we will start by pacing the patient externally. Some other indications would be cardiac blocks. So the patient is in a Mobitz type 2, the patient is in a 3rd degree heart block, metabolic and electrolyte issues. So the patient has, their chemistries are all out of whack, their potassium is very high, their potassium is very low. They may require to be paced if they're having different types of arrhythmias or they're bradycardic or tachycardic. Chest and cardiac trauma, injury to the sinoatrial node, which is the primary pacemaker, the natural pacemaker of the heart. So if there's some sort of injury to this node, that can disrupt the conduction system of the heart. So typically you'll see this occur in patients that had cardiac surgery. So a CABG, coronary artery bypass graft, patients that had valve surgery, patients that had a cardiac transplant, perhaps they could have some injury that was sustained to the sinoatrial node, so the conduction system is not working properly. Often we'll see patients with drug-induced bradycardia, so patients who took too much of their digoxin, now they're in a dig toxicity and they're bradycardic. Or patients in ACLS situations, so patients in advanced cardiac life support who are in a cardiac arrest from bradycardia. So patients that have very low heart rates or patients in asystole, sometimes we'll use the pacing method to see if that can help the patient be revived. Some contraindications to pacing would be patients who are non-symptomatic but in heart blocks. So patients who, for example, have a first-degree heart block, but they feel completely fine. They're not having chest pain, they're not feeling dizzy, or patients in Mobitz type 1 who are also not symptomatic. So I'm going to focus my presentation on transcutaneous pacing, which is what we most often do in emergency situations. So transcutaneous pacing can be done through the implantation of cardiac wires. So the wires actually, they're implanted transcutaneously, but they go directly into the heart. They can also do intraesophageal pacing or transcutaneous pacing with external pads, which is what we most often do, which is what I have seen most often in the ER. So now I'm going to show you a little bit about how this is done. Just one moment. Okay, so I'm sure everybody is familiar with this device. Here is our Zoll monitor and our code cart. So I'm going to show you now how you can do transcutaneous pacing in the ER. So you have your pacer pads here. So you're going to open up your package and you're going to place these on your patient. So this isn't Mary because Mary did not require transcutaneous pacing. So we'll call him Bob. This is Bob. So we're going to take off our stickers here. Sorry, just one moment. We're going to take off our stickers here and we are going to apply them to the patient's chest. So we're going to put one here and one down here. You want to be sure not to place the pacer pads above the pacemaker if the patient does have a pacemaker that's not properly sensing. That's really important. Typically in this situation you would want to have one pad on the chest and one pad on the back, but because Bob here is very difficult for me to roll, I'm just going to be putting them on the front just to show you what exactly they look like. Here's our Zoll monitor. Larry will be giving us a lot more information regarding this, but I'm just going to give you some brief instruction on how to externally pace a patient in the ER. So the first thing you're going to do is put it on the pacing mode. So your monitor will come on. You want to make sure when you are doing transcutaneous pacing with a patient that you have them connected to your cardiac monitor in the room as well, or to the EKG machine, so that you can be monitoring them very closely, monitoring their oxygen saturation, their blood pressure, and their heart rate as well. So the next thing you're going to do is you want to be able to achieve capture. And the way in which you do this is through the milliamps, as you can see here. So what you're going to do is increase your output or your milliamps until you achieve capture. So you're going to increase your milliamps. You'll see them increasing here. It's usually patient dependent. So what you're going to do is increase these until you achieve capture. And essentially what capture is when you have a pacing spike and then you have a QRS with every pacing spike. That is when you achieve capture. A pacing spike and then a QRS with each spike. So say you achieve capture at 50 milliamps, you want to go up another 5 to 10 milliamps above your threshold, and that is where you will keep your particular that's where you will keep your particular output. You're also going to have the rate set, which is usually determined by the doctor. Typically in a pacing situation, you'll have the rate set to 60, usually 60 to 80, 70 to 80 is most common in the emergency department. You just want to keep in mind that when you're externally pacing a patient, this can be very painful for them because you are sending small electrical shocks to the heart to keep it functioning properly, beating at an appropriate rate. So unless it's a life or death situation, you really ideally would like to put an IV line in, give the patient some Valium, Versed, some morphine, something that can help them feel a little bit better, because for as long as they're being paced, it is going to be a very painful process for them. So this is the rate that we love to see. This is a normal sinus rhythm with a heart rate in the 70s. This is 72 right now. So say you have a patient that comes in with this heart rate. What heart rate is this? This is a sinus bradycardia. So this is a heart rate in the 40s. Patients may have either symptoms or they may not have symptoms. But if they come in and they're presenting with symptomatic bradycardia that is not responding to atropine, this patient will require transcutaneous pacing. You also may see a patient in this heart rhythm. So you'll see you have P waves that do not have an associated QRS. So this is a heart block. This is Mobitz type 2. So you'd see a P wave and no QRS, as you can see here. A P wave and no QRS. So this particular rate may also require transcutaneous pacing. Then you have this rhythm. It's very sporadic. The P's and the QRS's are not talking to one another. There's really no communication between them at all. This is your 3rd degree heart block. So this patient may require transcutaneous pacing as well. So depending on the indication for transcutaneous pacing in the ER, the patient may or may not require permanent implantation. For example, if the patient was bradycardic from a drug-induced situation, then once the medication is out of their system, they may be fine. But if this is a patient that has a history of 3rd degree heart block, then they may require the implantation of a permanent pacemaker. So just keep that in mind. Also, just make sure you're walking your patient through all the steps of transcutaneous pacing, especially if it's their first time being paced. It can be a scary, nerve-wracking situation for them. So you want to just make sure that you're walking them through all the steps, answering any questions that they have, and making sure that you give them the appropriate medications if possible, so they're not in so much pain during this pacing process. So that's all that I have for you today about transcutaneous pacing in the ER and pacemaker interrogation. I hope that you enjoyed this video, and leave any comments or questions below. Thanks so much for watching. Bye.